Dental plaque is considered the main etiological factor for gingival and periodontal disease. Therefore, if we assess the patient's compliance and brushing technique, we will be able to instruct them, and their plaque control and oral health would be improved. Probing depth is a clinical parameter that measures the distance between the gingival margin and the sulcus or periodontal pocket. 6 points per tooth have to be registered in the periodontal chart: distal, medial and mesial, buccal and palatal lingual. These measurements should be done continuously around the tooth. If a mark falls between two values, we will record the highest one. 2, 2, 2, 2. And the same at palatal. We are starting at tooth 2.3 distally. During probing depth, we must also determine if there is or not bleeding. If we observe bleeding at probing, we should register in which area it is: mesial, medial or distal, buccal or palatal lingual aspect. The next clinical parameter we should evaluate is the relationship between the gingival margin and the cemento-enamel junction. This includes what is called gingival recession, that happens when there is an apical migration of the gingival margin under the cemento-enamel junction. On the other hand, pseudo-pockets where the gingival margin is coronal to cemento-enamel junction. Therefore, we can have 3 different clinical situations. If the gingival margin is at the cemento-enamel junction, we have a 0 value. When the gingival margin is apical to cemento-enamel junction, we have a real gum recession, and it is recorded as a positive value. And when the gingival margin is coronal to cemento-enamel junction, we have to record it as a negative value.
0, 0, 0. En cuanto a la encía adherida, ¿de acuerdo?
Regarding the attached gingiva, we usually register on the periodontal chart values of 2 or less. In order to determine the attached gingiva of each tooth, firstly, we have to locate the mucogingival line. In those cases where it is difficult to assess the location of the mucogingival line, the periodontal probe should be placed perpendicular to the longitudinal axis of the tooth and make a crease.
¿De acuerdo? Entonces, allí donde, ¿veis? Aquí. Allí donde se...
Where the crease ends is where we can determine the position of the mucogingival line. On the periodontal chart, we only write one number per tooth that matches with the value of the medial point. The value of the attached gingiva comes from the distance from the gingival margin to the mucogingival line. Which in this case is 9 millimeters. And you have to subtract probing depth value, free gingiva, which in this case is 2 millimeters. So 9 minus 2 is 7 millimeters. So in tooth number 1.2, we have 7 millimeters of attached gingiva. It must be evaluated in the all dental pieces.
Y como he dicho, se tendrán que anotar los valores de 2 o inferior.
To evaluate the furcation involvement, we must first determine how many furcations we have. The upper molars have 3 furcas: buccal, mesial and distal. The buccal must be evaluated from buccal using a neighbour's probe, and the mesial and distal furcations from palatal. At the level of the first upper premolar, we can find a mesial and distal furcation. Tooth mobility is assessed with the blunt end of 2 instruments, and it is classified into types 1, 2 and 3. Type 1 is when the buccal palatal lingual movement is less than 1 millimeter. Type 2 is established when the movement is more than 1 millimeter. In type 3, there is a horizontal movement and also an apico-coronal mobility. Scaling and root planning is included in phase 1 of the periodontal treatment. The aim of this phase is to mechanically remove supra and subgingivital deposits, as well as to smooth the root surface. By scaling and root planning, we can eliminate supra and subgingival deposits mechanically. The instruments that are most frequently used are periodontal curettes. There are various types. In this case, we are using a Gracie Mini 5 and 1, 2. The way to hold the instrument is by the modified pen technique, in which the ring finger acts as support. It is very important to have a supporting point, both at intraoral and extraoral. At the level of the incisors, the closer we are to the work area, the greater control of the instrument we have. The teeth that we are going to scrape will be those that have a probing depth of 4 or higher. Scaling and root planning due to the pain should always be done under local anesthesia. We can use a plaque revealer liquid to control the plaque. The patient should place the tip of the tongue toward the palate, and we will apply 3 drops of the revealer underneath the tongue. Then the patient can close the lips and pass the tongue all around teeth surfaces. We should record the areas that are marked.
Aquí, por ejemplo, no tenemos nada de revelador, sin embargo, en esta superficie que sería la distal, deberíamos anotar. Entonces, haremos de 3 a 3, ¿de acuerdo? A nivel del
1.3 Distal and mesial. 1.1 Distal. 2.1 Mesial and distal. 2.3 Palatal. 2.2 Palatal and 2.1 Palatal. Because you have gingival recessions, we recommend that you brush your teeth with a modified Stillman brushing technique. To perform the modified Stillman, position the bristles of your toothbrush at a 45-degree angle to your gums. This means you will hold the brush at the gum line and point the bristles towards the tooth's root. Once here, you can use a vibration and roll motion to clean the surface of the tooth. Vibrate the bristles gently against the gum line and then pull the brush to the biting or occlusal edge. With the dental floss, you should take about 20 to 30 centimeters. Roll it with the middle finger of each hand and work with the index finger and thumb. It is very important that you make a sliding movement to overcome the contact point of the teeth. Once done, you can clean both sides.
Ya puedes ir hacia un lado y hacia el otro.